Hello. Welcome to this lecture on pneumonia as a trigger for sepsis. My name is Dr. Andrew Conway Morris. I'm a clinical academic at the University of Cambridge and an intensive care physician at Addenbrooke's Hospital in Cambridge. And I have a clinical and research interest in the immunology of critical care, sepsis, and pneumonia. These are my conflicts of interest. So when we're talking about pneumonia as a trigger for sepsis, we're going to cover a number of topics. We'll talk about what pneumonia is and how it's defined. We'll talk about the microbial causes of pneumonia. We'll talk about how pneumonia can lead to sepsis. And then we'll talk about the management of the septic patient with a focus on the specifics required for pneumonia. I should also say that there is a 3-part lecture series for those seeking more information on pneumonia as part of the critical care medicine track on Continuous. So what is pneumonia? Pneumonia is defined by alveolar infiltration in response to an infecting pathogen. What we see macroscopically is consolidated, heavy lungs, and microscopically we can see dense neutrophilic infiltration, and perhaps a little bit more rarely, diffuse alveolar damage with the formation of hyaline membranes. And of course, diffuse alveolar damage is the hallmark of ARDS, of which pneumonia is the single commonest trigger. Pneumonia is very common in the ICU. It makes up about 60% of all infections encountered in this setting. Perhaps 20% of patients hospitalised with community-acquired pneumonia will require ICU, although the proportions will vary depending on which setting you're working in and the availability of ICU beds. Hospital-acquired pneumonia, slightly lower frequency of admission to ICU, perhaps 3 to 5% of patients with HAP requiring ICU. And of course, ventilator-associated pneumonia, which by definition develops in ventilated patients in the ICU, may complicate up to 10% of the stays of all ICU patients. When we look at the mortality for hospitalisation, we can see that patients hospitalised with CAP, not just those going to ICU, but they have a mortality of about 3%. Patients in hospital with hospital-acquired pneumonia, a mortality of about 13%, which suggests perhaps more of those should be admitted to ICU. And of course, ventilator-associated pneumonia, which as we've mentioned can only occur in ICU, has a mortality associated of about 17.5% to 18%. Of course, for HAP and VAP, it is difficult to disentangle those mortalities from the underlying condition that brought the patient into hospital or into ICU in the first place. When considering pneumonia as a trigger for sepsis, it's worth remembering how sepsis is defined. So, of course, as you I'm sure are aware, sepsis is organ failure arising from infection, and we define organ failure by a SOFA score of greater than or equal to 2. And unsurprisingly, given the site of infection, the commonest organ failure in pneumonia is respiratory failure. Remember that a PF ratio of less than 300 millimeters of mercury or 40 kilopascals will give you a score of 2 points, organ failure by our sepsis definition. So what does that mean practically? Well, it means that any patient who needs more than 25% oxygen to maintain their PO2 above 75 millimeters of mercury, 10 kilopascals, arising from pneumonia, has sepsis. So the bar's relatively low. And remember that when a patient develops sepsis, that automatically puts them into a higher mortality risk group. And when we look at what the best triggers are for predicting a patient's need for ICU, organ failure is the best trigger. There are a variety of pneumonia scores out there, but none of them perform as well as the SOFA score for predicting who needs to come to ICU. Perhaps a slightly circular definition: if you have organ failure, you need to come to ICU, therefore organ failure predicts ICU admission, but nonetheless, that is the best data that we have for prediction. It's important to remember that pneumonia isn't really a single diagnosis, rather a syndrome arising from a range of different infecting pathogens: viral, bacterial, atypical organisms, fungal pathogens, and these can all trigger sepsis. Identifying the source is critical. If you know that a patient has a pulmonary source, has pneumonia, then you can predict the likely organisms that will be there and therefore guide your empiric treatment. You can also help with prognostication and predicted clinical course, and of course looking for sources when looking for the need for source control. If we consider pneumonia compared to other triggers of sepsis, as I've already mentioned, the most common organ failure is, of course, respiratory failure. And the rate of respiratory failure in pneumonia is twice that seen in sepsis of non-respiratory sources. Septic shock is common, no more so than abdominal sepsis, and a little bit less common than catheter-related bloodstream infections or sources of uncertain origin, but still a significant problem. Acute kidney injury again is common, although rates are not in excess of those seen in other sources of sepsis. Because of the predominance of respiratory failure with other organ failures, multi-organ failure, so failure of 2 or more organs, is more common in pneumonia than in other sources of sepsis. And if one adjusts for the various confounders that are around in mortality analysis, we find that the mortality associated with pneumonia is similar to that seen in bloodstream infections and sepsis of uncertain origin, but greater than the mortality seen in abdominal or urinary sources. So a significant problem, and one that needs to be taken seriously. If we look at the underlying immunology, there's significant overlap in the blood-based markers of inflammation across the various triggers for sepsis. So this is a recent study from the Mars Consortium, and you can see here pneumonia in the left-hand column in the teal colour. You can see significant overlap with the inflammatory cytokines, the endothelial activation markers, and the coagulation markers with other triggers for sepsis. And if we have a look at the study here from the Gaines Consortium, we can see comparing pneumonia with fecal peritonitis, the pneumonia in the clear circles, the fecal peritonitis in the solid circles. We can see that the two groups of patients by source are intermingled, and really what separates them is their genotype patterns falling into these two SRS1 and 2 phenotypes, which were identified by the Gaines investigators. And you see here in crosses, a group of patients with cardiogenic pulmonary edema really quite separating themselves out. Now, clearly, there are differences at the compartmentalized or tissue level for the different sources of sepsis. But the blood, which samples all tissues and is arguably what the rest of the body sees, there's more in common between the different sources of infection and sepsis than separates them. And when we think about the management of patients with pneumonia and sepsis, perhaps the first challenge that comes to us is respiratory failure and the need for mechanical ventilation. And it's important to emphasise that the single commonest trigger for acute respiratory distress syndrome is indeed pneumonia. So there is an argument that severe pneumonia and ARDS are almost synonymous. Perhaps not quite that strong, but certainly the evidence that we have from the evidence we have from ARDS literature applies to severe bilateral pneumonia. Clinically, ARDS is associated with different histological pictures, both the diffuse alveolar damage pattern, which is the sort of classic pathognomonic histological picture, but also histological pneumonia. And as I've said, the evidence from the ARDS literature applies to severe bilateral pneumonia. So low tidal volume ventilation, ventilating patients in the prone position, keeping them dry, and a low threshold for the use of muscle relaxants. In terms of optimal mode of ventilation, how to set optimal PEEP, the use of recruitment manoeuvres, and driving pressure as a way to titrate mechanical ventilation, the evidence here in ARDS is uncertain, and similarly, so it is in pneumonia. An interesting question is to what extent the data from the ARDS literature, where patients are defined by bilateral infiltrates, applies to patients with unilateral infiltrates. A recent study looking at the lung-safe cohort in a post-hoc analysis looked at patients who had two-quadrant infiltrates on the same side, so unilateral but bilobar pneumonia. And they found that the outcomes there were very similar to those of patients with bilateral ARDS. So it may be that the data from the ARDS literature can also be applied to severe bilobar pneumonia. However, this remains hypothesis generating, and at the moment, the evidence is uncertain. It is, of course, vital to understand the microbiology of the patient with sepsis in front of you, as that will help guide your empiric therapy. The commonest group of organisms causing pneumonia are bacterial, gram-positives, which in community-acquired pneumonia is almost invariably Streptococcus pneumoniae if it's a gram-positive, much rarer to encounter other gram-positives, intracellular organisms, the atypical organisms, and a relatively rarer number of gram-negatives, although, of course, Haemophilus influenzae is a major community-acquired pathogen. Clearly, in hospital-acquired pneumonia, this is quite different, where the gram-positives predominantly are Staph aureus, and there are many more gram-negatives, and especially multi-resistant gram-negatives. The next largest group of organisms that cause pneumonia are the viruses, making up about a third of community-acquired pneumonia, where we're able to identify a pathogen. And generally thought to be less of an issue in hospital and ventilator-acquired pneumonia, although that may be partly because we haven't been looking for them. The smallest group of pneumonias arise from the fungi. These predominantly occur in patients who are immunocompromised, and in that group I would include patients who've been in the ICU for more than a few days on ventilators, especially those who've received corticosteroids and or broad-spectrum antibiotics. So if we were to quantify that a little bit more, we can see here hospital-acquired pneumonia, Staph aureus, Pseudomonas, Enterobacteriaceae, Aspergillus are the sort of common or dominant organisms, quite different in those arising from the community, where strep pneumo, Haemophilus, viruses, and the atypicals make up the majority. Now, of course, the problem here is that the single biggest group of pneumonias we encounter is culture negative. We'll come on to talk a little bit about that shortly, but this does make it more challenging to identify what the causative organisms are and to know what we're dealing with. Because of the difficulties with microbial cultures, which we'll discuss shortly, we tend to classify pneumonia by their site of onset. So community-acquired pneumonia, as I said, predominantly intracellular, the atypical and gram-positive organisms, and respiratory viruses with a few fungi, but that's, fungi are pretty rare in that setting. Hospital-acquired pneumonia, many more gram-negatives, a few gram-positives, and fungi more predominant, and we do see some viral hospital-acquired pneumonia, and of course remember that ventilator-associated pneumonia is really just a subset of HAP. And then, of course, the important thing is to say patients with immunocompromise who are at risk of all the standard causes, but one must also consider the opportunistic infections that may infect those particular group of patients. When it comes to diagnosing pneumonia, as I mentioned at the beginning, fundamentally pneumonia is a histopathological diagnosis. However, getting a tissue for diagnosis in a patient, at least ante-mortem, is challenging in the ICU, to say the least, and very seldom undertaken. So therefore, we need to rely on proxy measures. So we use measures such as clinical findings, whether the patient has crepitations, bronchial breathing, purulent sputum, worsening gas exchange to suggest a pulmonary focus. We use radiological investigations to look for evidence of alveolar infiltration, so diffuse or lobar infiltrates, look for air bronchograms and so forth. And we look at laboratory assessment of host inflammation. So what we're getting here is a combination of a pulmonary focus with alveolar infiltration and evidence of inflammation to suggest that it's an infectious process. Now, the problem is that all of these three are quite non-specific, and to confirm a diagnosis of pneumonia, we really do need microbiology, be that culture, antigen-based or PCR-based. But these all combine to give us our proxy measure. Now, when thinking about microbiology, there's a discussion which continues to this day about the use of less invasive endotracheal aspirate or sputum versus bronchoalveolar lavage. Broadly speaking, that's a trade-off between sensitivity and specificity, with bowel being more specific, but endotracheal aspirate possibly being more sensitive. Blood culture should be taken in everyone, although the yield is relatively low. And pleural fluid, if present and safely accessible, should also be sampled, particularly if one suspects empyema. All of these combine as a proxy for the histological diagnosis. Now, the problem, as I mentioned, is with culture negative infections. And really, the reason for this is because we're still largely using 19th century technology based on cultures and getting organisms to grow in order to identify our causative organism. So here we are, we have a patient who we think has pneumonia. We're taking a sample at this point, at point of suspicion of infection. This is when we'd like to have an answer within 1 to 4 hours, at the same time as all of our other tests start to come back. But the reality is we often don't get an answer until 48 to 72 hours, and only some of the time. And this is a major hindrance in guiding appropriate and effective antimicrobial therapy. Now, we are, I think, on the cusp of a revolution in microbial diagnostics with the advent of a number of molecular platforms which are able to detect organisms. So these detect nucleic acids, DNA, RNA, rather than relying on growth, and therefore are a lot more sensitive. They're very fast. You can get an answer within 1 to 4 hours. There is the potential risk that it might be too sensitive. They detect things that we otherwise wouldn't have been aware of. However, the data to date suggests that they do reduce antimicrobial intensity despite being more sensitive. The impact of these devices on patient outcomes in terms of length of stay in the ICU or mortality is uncertain, even in the recent randomized controlled trials. But I think these are going to be a major part of how we manage patients with pneumonia in the near future. Of course, antigen detection is better established and has been around for a long time. Galactomannan for the detection of fungi, Aspergillus specifically, and urinary antigens for Legionella and streptococcal antigens. These all have their perils and pitfalls, so it's important to understand how these tests work, but they do make a useful contribution to our management of pneumonia. So which empiric antibiotic should we choose? And it's vital that we get the right ones. We want to make sure that our coverage is suitable for the organisms that we suspect are there, and remember the difficulties that we have with detecting organisms, but also not unduly broad. So think about, where did the patient acquire the infection? Was it in the community? Was it in hospital? Where have they been in the world recently? Have they been in areas that have different antimicrobial resistance patterns to the ones that you're used to? And what is indeed your own local antibiogram? Have they had recent prior antimicrobial therapy? Because if they have, the likelihood of them having an organism that is resistant to those prior antibiotics is significantly higher. And this is obviously particularly an issue for patients who've been in hospital recently. Is the patient known or suspected to carry a multi-drug resistant organism, in which case your antibiotics have to cover that organism, either because that's likely to be the cause of infection or to avoid selecting it out further. Is the patient immunocompromised? And if they are immunocompromised, what type of immunocompromise do they have? Are they at risk of opportunistic or unusual organisms that you need to cover? And of course, does the patient have any allergies which preclude particular antibiotic choices? Now, whilst you should consider all of these factors, the fundamental point with the choice of antibiotics is that you should follow your local guidance, which has been developed by those with knowledge of the local antibiogram and preferences for local antibiotics. But broadly speaking, for community-acquired pneumonia, a beta-lactam and a macrolide will give you good coverage of both gram-positive and community-acquired gram-negatives and atypicals, or levofloxacin, which is the only fluoroquinolone that is recommended for community-acquired pneumonia as monotherapy. In hospital or ventilator-associated pneumonia, one requires an anti-pseudomonal cover, so anti-pseudomonal penicillin or vancomycin and ciprofloxacin. And for the immunocompromised, consider whether you need fungal cover. Do you need cover for Pneumocystis jirovecii? But as I say, these are all broad outlines, and one should use the local guidance. If your patient is deteriorating or not getting better, think about the 3 Ds. So think about the drugs that you're using. What organisms are you missing from your empiric coverage? Think about the dose. Are you using the correct dose for the patient, particularly in patients who have enhanced renal clearance? And thirdly, have you got your diagnosis correct? Is pneumonia actually the source? Do they have an additional source, such as do they have an additional source, such as an empyema, or indeed a non-pulmonary source entirely? So consider all of these 3 factors when looking at a patient who's not getting better. In terms of adjuvant therapies, the success of corticosteroids in COVID-19 has prompted considerable interest in adjuvant therapies. Corticosteroids clearly have a proven role in pneumonia arising from COVID-19. They also have a role in patients with septic shock arising from pneumonia. However, the widespread use of steroids outside of those contexts cannot be recommended. Retrospective studies do suggest an increase in mortality in influenza, and there are trials going on in this area at the moment to clarify that. In community-acquired pneumonia, there have been trials of corticosteroids. Whilst the balance of evidence may be just about in favour, certainly this is not definitive, and studies do give us conflicting results. So I think at the moment it remains unproven. In patients with pneumonic exacerbation of COPD, steroids are standard, although the evidence here is not strong. In patients with undifferentiated ARDS arising from conditions other than COVID-19, I would say at the moment this remains experimental and should be the subject of randomized trials, not empiric therapy. So, as I say, aside from COVID-19, more data required here. And in terms of other adjuvant therapies, various ones have been trialled: GM-CSF, G-CSF, antibodies, IVIG, vitamin C. None of these are proven in the least, and I would not be using them out with the context of a well-designed, randomized, controlled clinical trial. So, to summarize, pneumonia is a common trigger of sepsis and thus a common trigger for ICU admission. Respiratory failure is the commonest organ failure, but shock and AKI are seen at rates approaching those from other sources. So pneumonia is a common cause of severe infections and sepsis. It's the commonest trigger for ARDS, and the evidence from ARDS applies to patients with bilateral pneumonia and may also, to some extent, apply to patients with 2-quadrant unilateral infiltrates. However, that remains to be confirmed. The selection of appropriate antimicrobials is absolutely essential, and our empiric choice should be guided by various factors and requires careful history taking to determine. Effective microbial diagnostics are the key to refining antimicrobial therapy, and with the advent of molecular diagnostics, we are going to see a significant change over the next few years. And remember, if the patient is not improving, consider the 3 Ds: the drug, the dose, and the diagnosis. In terms of adjuvant therapy, steroids are proven in COVID-19 and in septic shock, but there are really no other proven indications for their use. So thank you very much for listening. If you have any questions, please do feel free to reach out via these routes. Thank you.